Thank you.
Thank you, sirs, for a great discussion. Now we proceed to the next session, the Endocrine Symposium. To start with, we are going to have a talk from Professor Karim Miran from UK. To chair this session, we have Dr. Bala Murugesan and Dr. Lokesh. Dr. Bala Murugesan has done his MD from PGI Chandigarh. He is presently working as Additional Professor of Medicine in JIPMA, Puducherry. He was a former HOD in IGMC. He is a coordinator for various committees and he has had multiple publications. Dr. Lokesh has done his MD in General Medicine and presently he is the professor and head of the department in Mahatma Gandhi Medical College, Puducherry. His main interest is in communicable diseases. He also has multiple international and national publications. I request the chairpersons to please introduce the speaker.
So, good evening, everybody. Am I audible?
Yes, sir.
Thanks to the organizer for giving me the opportunity to chair the session in Endocrine Symposium. So today we are going to have a topic on adrenal insufficiency. It's a very important topic in perspective to the internal medicine as well as the endocrinology. This topic is going to be presented by Dr. Professor Karim Miran. He's Professor of Endocrinology from Imperial College London, and he's also a Deputy Director of Medical Education, a lead clinician for endocrinology, and he's a teacher for excellence. Is basically endocrine masterclass program. He's also conducts masterclass programs for various physicians. And his research area of interest or glucocorticoid replacement for adrenal insufficiency. Basically, this adrenal insufficiency nowadays is getting so much importance. Without wasting much time, I hand over the proceedings to Professor Karim Miran to take into that session, interesting session. Welcome you, Doctor.
Thank you very much. Can you hear me? And shall I share my screen?
Yeah, you can share your slides.
I will share my screen. Okay. So I'm going to not say anything that you don't know really, but I'm going to encourage you all to think about doing some research for patient benefit, which is something that I'm very, very keen on trying to spread around the world. So this is something that we all learned in medical school about the production of steroids, and the two important steroids that I'm going to talk about today come from the adrenal cortex, and they are cortisol, which is what I'm most interested in, and then also aldosterone. And if you've got primary adrenal failure, of course, you miss both of those, and therefore we need to replace both of those. And my real interest is trying to work out the most optimum way of replacing steroids without causing the side effects that we have got used to accepting. So that is a bad thing. We're giving too much steroid, and we are causing premature cardiovascular death as a consequence. And that's something that I'm getting more and more data about. One of the problems, I will be honest with you, is we are very bad at replacing these steroids, okay? The problem is that aldosterone has a half-life of only 20 minutes. Cortisol has a half-life of 66 minutes. So if you take it once daily, those native substances, they're gone very, very quickly. So this is the molecule aldosterone. And as I said, because the half-life is only 20 minutes, we can't use it. It's very good for a hormone to have a short half-life because it enables the system to regulate it. So if you want it to disappear, you just stop producing it and the levels fall quickly, which is very good for blood pressure control. But if you don't have it, that is not a convenient way to go forward. So we have modified the molecule. We've put a fluorine atom into the middle of the molecule. Now, fluorine does not exist in nature. It's not a normal molecule. So when you put fluorine into a molecule, you make it non-biodegradable. And therefore, the normal enzymes that metabolize aldosterone cannot do that. And so fluorocortisone has a very long half-life, okay? Its presence, the fluorine atom presence makes it last a very long time, maybe between 3 and 18 hours. So that's very convenient. So a lot of our drugs are basically hormones that are modified in a way to make them last longer. Okay, and we tend to use in primary adrenal failure between 50 and 100 micrograms daily of fluorocortisone. That will be an optimum. Because cortisol has a very important diurnal rhythm with, as all of you know, a very low level at midnight and then a peak in the morning. And in this study, we found that the level starts to rise at about 5 in the morning in someone who wakes up at 7:30. And the peak is shortly after you wake up, okay, at about 8:30. And this was in a study looking about 10 years ago by Ross and his colleagues, looking at levels of cortisol in healthy people. Okay, and you can see there's a lot of variance because there's lots of differences, and we call it stress, but we are not good at defining stress. So this is what happens if you take somebody who's not got any cortisol and you give them a single dose of that molecule cortisol. The level shoots up very quickly when you give them this dose here at 8:30 or 8 o'clock, and then it rapidly declines. By 1 o'clock, it's all gone. So cortisol is too short a half-life to use once daily. And therefore, we give it more than once. Okay, so the second dose and the third dose. So this is the kind of preferred recommended regimen. But I will say that the evidence for giving it 3 times daily does not exist, except in measurements. We don't know that this is a good thing to maintain the levels. And now we're beginning to see that these late levels may be harmful. Okay, a level here, a big peak there is not natural. Okay, so we're beginning to see that this is having an effect on your biological clock. Now, this, of course, assumes that you're awake in the day and asleep at night, which most of us are. So if you have late peaks, that seems to be a bit harmful. This is from a study looking at peripheral acetylation of all the glucocorticoid receptors. Okay, so these are receptors in the periphery, in the liver, in the brain, in other parts of the body. And it seems that our target tissues all have got endogenous clocks, and they all change their sensitivity to cortisol as the day progresses, so that the acetylation falls in all of your tissues, and at the same time, you become more and more sensitive to glucocorticoid. So by midnight, a small dose of cortisol has a big impact on the system downstream. And then in the morning, you become less and less sensitive. So a smaller dose is more effective. So it seems, if we assume, and this is an assumption I admit, that cortisol is a wake-up hormone, then if you have it in the morning when you are less sensitive, and then none later on, that is probably a better thing. But the main problem really is an even dose of hydrocortisone is very potent. And if you are not in some emergency, then it possibly is unhealthy. So this is what happens if you give someone at the level we want to look at. And this is what happens if you give it 3 times daily. It goes up, down, up, down, up, down. And I'm concerned, but I'm not sure about this, that those late peaks are harmful. This is a hypothesis, okay? And that's because of the half-life of cortisol being too short. But up to now, we haven't questioned it. We've just given it 3 times daily. And no one has looked at the differences between these two molecules. Now, prednisolone is obviously not a natural substance. Prednisolone has got a double bond that also does not naturally exist. And that gives it a longer half-life, and it also makes it bind to the receptor more avidly. So because of that, it's quite a potent, nice, long-lasting steroid. And we have set up an assay for this, a mass spec assay to measure prednisolone levels. And we've been very surprised, because it seems that you can achieve very good levels with very, very small doses of prednisolone. So all these years I've been teaching and learning that prednisolone is a harmful molecule, it causes side effects, but that's because we've been using too much. And if you look at the time curve of prednisolone, I'm beginning to think that prednisolone actually is a better drug for replacement than hydrocortisone, because this is the day curve of somebody who takes a single dose of prednisolone and it gradually wears off. And it's very much like what we want, okay? Unlike these unnecessary peaks later on, but it does need the molecule prednisolone with that double bond in there. It's the only difference between prednisolone and hydrocortisone in terms of the molecular structure. So 3 milligrams, pretty small dose, is what I'm using. Now, we in the UK have 1 milligram tablets, and so I've been trying different doses out, and we don't actually know what the best dose is. But I'm finding that lower and lower doses are effective. And the other good thing about prednisolone is it's very easy to absorb, rapidly absorbed. Within half an hour, we have a nice peak level. Obviously, it's not as good as having it before you wake up, which is another bit of research, but that'll be very difficult to achieve, but this is easy to achieve. So we started doing lots and lots of different day curves, and we started changing and trying out different doses of prednisolone and hydrocortisone. And we have come to one assumption in this study with quite a large number of patients that about 3 to 4 milligrams is the right replacement dose. And on this, if you measure levels, it mimics the circadian rhythm better than any other steroid, and definitely better than hydrocortisone. Okay, but this was, I'll just move this black blue out of the way. This was, we published this in 2016. Okay, so that was our first move away from hydrocortisone, because in the UK, everybody uses hydrocortisone, saying it's better. But we started in this research, and I'm thinking maybe that is not the case. So we then did a larger study and looked at, because people were worried about the cardiovascular risk profile. They said prednisolone is very potent. All our patients get osteoporosis and heart disease. And so we compared them. And if you give low dose prednisolone, then we don't find that. So this is a study looking at a number of people on hydrocortisone, 20 milligrams, which is a pretty standard dose on average. That was 10 plus 5 hydrocortisone, compared to between 3 and 4 milligrams once daily of prednisolone. And everything we measured was not worse. Okay, in fact, some things were better. What was most improved was satisfaction, because it's so easy to take it once in the morning and forget about it, rather than having 3 doses daily. So up to now, I've been reserving prednisolone for people who may be non-compliant, but now I'm thinking we should give it to everybody, because it's actually not worse, and it might be better, and it's easier to take. But my real interest is to find out what is really the best treatment. What I'm becoming more sure of is that if you study 5 milligrams, then you won't see a benefit, because 5 milligrams is more than endogenous need. It's very good if you've got some autoimmune disease to have more, but if you are normal and you just want to replace missing adrenal function, we're giving too much. You've got to cut the dose down to about 3 or 4, maybe 2.5. I'm having some suggestions from some colleagues in some parts of the world. So after we published that, other people started agreeing with us. And this is one study suddenly saying it's now common knowledge that regularly used twice or thrice daily hydrocortisone replacement is non-physiological. So everyone says, yeah, don't use hydrocortisone. They're not yet ready to say we should use prednisolone, because we need evidence. And that's why I want everyone to help in trying to generate evidence for this. So let me tell you what the evidence that I think we have so far is for prednisolone. Okay, I'm obviously an advocate now of prednisolone. It's very, very cost effective. So if you surf the literature, you start to find that other people have said the same thing, but it's all gone into small journals and everyone's ignored it. But this is a very good study looking at a condition that you all know of called congenital adrenal hyperplasia. And the reason that this is a good group to study is that they have an easy to measure endpoint, because the problem with Addison's patients is if you give a little bit too much, they feel okay. But the problem I'm worried about is in the end, we're going to cause premature cardiovascular problems. So in this study, they were complaining that hydrocortisone does not reproduce cortisol chronobiology. That's what I've been saying for a while. Okay, but this is before me. This was 2004. Okay, and they were looking at these children and they said they're not growing properly. And so we're going to compare hydrocortisone with a single morning oral dose of prednisolone. Okay, and it was a very nice study randomizing patients to thrice daily hydrocortisone or once daily prednisolone. Okay, and they looked at everything: bone density, bone growth. Remember that in CAH patients, there's growth that you can measure, and there are steroids, testosterone you can measure. There's other good outcomes you can measure: 17-hydroxyprogesterone. All these things we can't do in other patients. And I'll summarize the whole paper, but basically their summary was a single morning dose of prednisolone appeared to achieve better clinical and hormonal control than those on 3 times daily hydrocortisone. It's very clear, very good study, randomized. But what was very interesting was they said that the dose of prednisolone used was 6 to 8 times more potent than hydrocortisone. That's a really important message. In other words, 3 milligrams of prednisolone gave the effect of 20 of hydrocortisone. This is not what we teach people, and we should do, because this is basically good evidence. It's hidden in this journal, but they're not the only ones. This is from an old textbook. Even new textbooks are copying this. They say that cortisol 20 is the same as prednisolone 5, and therefore it's 4 times more potent. No, 20 of hydrocortisone is the same as 3 of prednisolone, and therefore it's 7 times more potent. So we need to start cutting the dose of prednisolone. And if we do that, we will have better outcomes than patients who are on hydrocortisone, is my hypothesis. Now, we need you to help us to do some research to find out really what is the best treatment. So we have got 1 milligram tablets. One of the things that we also have is enteric coated. And when I did some day curves, in other words, measured levels of prednisolone in patients taking enteric coated prednisolone, the absorption was erratic. It was delayed. And while that might be good if you have a big dose for, let's say, temporal arteritis, if you're worried about peptic ulcers, for replacement doses, a delay is a bad thing because you need, if you're going to minimize the dose, you need it to be absorbed. So I've stopped using enteric coated prednisolone because on our day curves, about 20% of people had either no absorption or very delayed absorption. And we can't have that. So what is a practical solution for countries where there is only prednisolone 5 milligrams daily? And I'm saying that's too much, and I want to give between 3 and 4. Well, one easy option, and I've checked out a lot of prednisolone tablets to see if it's uniformly in the tablet, and it seems to be, and that is, a lot of our patients do this. They break tablets in half if they're on hydrocortisone 10-5-5. We should do the same with prednisolone, but make it 3/4 of a tablet. In other words, that's a 5 milligram tablet. You break it in half and you can have 2.5, and you break it in quarter, and then you have a safe once daily dose. I don't know this is the case, so we need some evidence generating. So what we need to do is take our patients who are on whatever they are taking and measure a number of outcomes. And the outcomes are very straightforward. Things like blood pressure, obesity, BMI. These are things that all of us can measure, but we must measure it and record it. And then switch them to something we think is better, like a low dose of prednisolone. So let's say you've got patients, because I know a lot of patients around the world are on prednisolone 5 milligrams once daily and are very happy on that. And what I want to know is whether 3.75 milligrams will work just as well. Of course, we are confounded by other symptoms such as tiredness, things that we can't quantify. And when you reduce the dose, some patients do get aches and pains and other things. And there's a mechanism that we've found out for this. But I'm thinking that we need to do some research in this area. This is the reason, okay? We wrote this last year. There is no doubt now, if you compare patients on replacement in all countries of the world, including the UK, they have an earlier death than controls. And it's quite clear that the increased mortality is due to excess steroid exposure. So we need to minimize that. Now, of course, if we go too low, we will see Addisonian crises. And we're all scared of Addison crises. And when someone dies of a crisis, everybody knows. But when someone dies of a heart attack, nobody realizes due to too much steroid over years. So lots of people are dying before they should. And no one's attributing to the saying, well, he's died of heart disease. But it's due to our over steroid exposure. So that's why we have a duty to get the right replacement dose. So I've been writing things on our website to try and explain to patients and to other doctors how we can achieve the right replacement dose and how difficult it is to get it right. This is some of our research from the last few years looking at levels of prednisolone in the circulation. And interestingly, you see this bottom yellow man here, he's on 2 milligrams once daily, and he achieves quite good levels. Now, how we work out our levels, we've done a lot of curves on a lot of people, and we've titrated those down, and we've asked them questionnaires, made sure that they feel well before we've changed any doses. And these people all say they feel perfectly well. So we're in the middle now of a randomized blind control trial for the UK to compare prednisolone with hydrocortisone. And there's a number of different studies ongoing. There's one that is going on nationally and can be international. And obviously, if you want to try doing this, there are protocols available that I'm happy to share with you. I'll put an email address at the bottom there if you wish to get in touch with us. You can do the study yourselves. I'll just give you all the protocols and you can run it all yourself. And I just want to hear the results in the end. And if you publish something, that would be very good. I'll tell you what markers that we measure. We measure in the UK, we do bone density studies, and we measure all of the bone turnover markers, because one of the hypotheses is that too much steroid will cause osteoporosis. I mean, we know that's a fact, it's not a hypothesis, but in these doses, and whether we can reduce the bone reduction by looking at peptides that come from bone. The other thing that's easier to measure for the whole world is glucose and HbA1c, because if we can drop the HbA1c, then that's a good thing. And then in non-diabetes patients, we can look at insulin resistance, for example. So there's lots of things, but an easy way to do that is just measuring BMI and measuring blood pressure and measuring waist hip circumference. So this is my suggestion to everybody, and that is we should compare 3/4 tablet of prednisolone, which is available in every country in the world. That's why I think that's one note. And compare it with whatever you're already doing. It might be hydrocortisone 1055, it might be prednisolone 5 once daily, it might be twice daily prednisolone, and then measure things that you can measure easily, like HbA1c, BMI, waist-hip ratio. I've also put out a questionnaire for patients, because one of the problems is that some patients, when you underrun them, get aches and pains and feel a bit achy. And on the week of moving down from 5 to 3.75, you get problems sometimes. And so maybe an alternative is to have alternate days or something to make them not feel achy as you cut the dose. What is interesting on our day curves is when you reduce the dose, initially the levels fall, but if you stay on a lower dose, they seem to plateau out. And over about a month, patients start to acclimatize to the lower dose. Okay, well, thank you for your attention there. And I'm very keen to take some questions from the audience. And I'll put that email address back on there in case anybody wants to get in touch and would like to have our protocols. I'm going to put them all on a website. Thank you very much. Any questions from the...
Good afternoon. Good afternoon, Professor Miran. This is Dr. Kumar Tulsidas. I would like to ask you, in India, the checking prednisolone levels is a difficult task. It's not so freely available. And the treatment with prednisolone, should it be guided by the electrolytes, blood pressure, and the symptoms of the patient, and things like that? So when we change over, that would be a challenge.
Yes. So just to explain, in the UK also it's a problem. The assay is not available except in my hospital. We have set this up specially, and it's only because until we did it, we didn't know. Now that we know, other centers are doing this in the UK without the prednisolone level. It was just an introduction to explain to the other doctors that lower doses actually achieve surprisingly good levels. So now I'm not advocating, even we are not measuring prednisolone levels in these people, because for us it's a blind randomized trial. So we can't measure levels because we don't know what they're on. So you're absolutely right. It's a clinical study. And what I'm asking everybody around the world to try and think about is looking for a safe, in other words, do it very slowly. So if they're on prednisolone 5, I'm very confident 3.75 now, having done lots of patients, is secure and safe. Maybe going below that might be difficult. And so we need some other markers. So one of the other things I've done is I've set up a questionnaire, and maybe you can ask patients how they feel when they're on different doses of steroids.
Thank you. We have this methylprednisolone tablet in India, comes as 4 milligrams. Is said to be projected against equal to 5 milligram of prednisolone. So could be cut into half, and 2 milligrams of methylpred would be somewhere close to 3.75, because 3/4 cutting, many people may not be very adherent to the practice.
Yes. That's a good point. So if you cut it in half, that will be the equivalent of 2.5 milligrams. And you might be right, okay? So methylprednisolone 4, you're right, we've done the same measurements, is exactly the same potency, it seems, as prednisolone 5. So if you have half a tablet of methylprednisolone, that would be 2 milligrams, that would be the same as half a tablet of prednisolone, so 2.5 milligrams. I have got some patients on 2.5 milligrams once daily. It's a small number. I am a little bit worried it's insufficient, but the patients seem to be okay. I have one patient who is on prednisolone 2.5 and fludrocortisone 100 because she has proper Addison's disease. And I know she's under replaced because her ACTH is very high. But she's refused to go up because she likes being underreplaced, because it helps her keep her weight down. So this is dangerous. This is a slightly, in my view. Having said that, she's done it against my advice for 4 years, and she's still fine. Has had no crises. So as long as she's on fluorocortisone, can I ask, is fluorocortisone easily available?
Yeah, it is, Professor Miran. It is available.
Well, that's all right then, because as long as you're on fluorocortisone, because in some parts of the world we use hydrocortisone to cover both, because you have a little bit more hydrocortisone, then it has a little bit of aldosterone-like activity. So if you switch those to the prednisolone, I am not confident without fluorocortisone that will be safe. But if you, I mean, what I'm advocating in the UK now, and I'm a minority at the moment, is prednisolone 3 to 4 with fluorocortisone 50 to 100 once daily in the morning.
Thank you, Professor Miran. Thank you.
Actually, there is a question from audience. Dr. Pankaj asked that, what about the growth suppressive effect of prednisolone versus other steroid? I think whether there are any head-to-head trials and those things, I think Dr. Karim Miran can clarify.
Yeah, that's a really good question, right? So, and it's not answered except because everybody around the world has used 5 milligrams. So your point is correct. If you use 5 milligrams, it has a lot of undesirable effects: growth suppression, osteoporosis, hyperglycemia. So my hypothesis, and up to now, 3.75 or lower does not have those effects. But I need evidence. So I'm not 100% sure what I'm saying. I'm saying that the preliminary data we have is reassuring. And so I'm telling my patients, you don't need to take hydrocortisone 3 times daily, take prednisolone once daily, but we have got ones, you see, so I'm telling them all to take 3 milligrams once daily. It is possible, when I'm a bit more confident, I'll be saying 2.5 milligrams. As I pointed out, I've got some patients on 2 milligrams, but that's a minority. And I'm still a bit nervous, but maybe we'll prove, if we have enough patients, that we need lower and lower doses.
Okay, sir, actually one more question. It is always we should give fluorocortisone for all the patients who are having adrenal insufficiency, or it's only for primary adrenal insufficiency?
Only for primary. Only for patients with primary. So for secondary adrenal failure, prednisolone is very safe, okay? Because they've got aldosterone, they're not going to have a crisis. But the primary adrenal patients, we have to be very careful with and make sure that we don't have a crisis, because that will cause a lot of a problem. There'll be deaths if we're not careful. So if you have any anxiety, one option is to only do this study in patients with pituitary disease. Yeah, then you're definitely safe.
Is there any more question from audience?
Yeah, I'm Dr. Sundar Raman.
Yes, sir.
Can you hear me? Yeah.
Yes, sir.
Thank you, Professor Karim, that it was an interesting, lucid presentation. You were very, very correct that we had a lot of congenital adrenal hyperplasia in the pediatric age population. And we found that the prednisolone was more useful than hydrocortisone in correcting their 17-OHP. In fact, prednisolone was a sole replacement, because at that time we didn't have fluorocortisone in India. So it took care about the melanocorticoid also. So you are very correct that prednisolone definitely have a greater edge over hydrocortisone, I think so. It was very interesting, and I'm really convinced that prednisolone is more to be used than hydrocortisone, because a lot of books says that hydrocortisone is the standard therapy in pediatric population. But your talk has shown that prednisolone is definitely having edge over hydrocortisone.
This is very helpful, because your statement of that makes me feel more confident, because I need more evidence, because I'm still a minority of advocates.
No, because practically I've seen that prednisolone is more effective in controlling 17-hydroxyprogesterone than giving hydrocortisone. And we didn't have fluorocortisone earlier. And with prednisolone alone, we were able to achieve the melanocorticoid effect.
That's very helpful. Thank you for that. That's really, really helpful.
Ask a question. So good evening, Professor Miran. It's nice to see you. And
yes,
he's my program director when we worked in Northwick Park. And I think he guided me with the initial endocrine aspects. I think he was programmed on his enthusiasm never stopped, and it looks like that I think the steroid interest from those days is continued, and it was an excellent talk. Now, but I just want to ask about the hydrocortisone, the Birmingham. If I remember, the data of Hyzone or hydrocortisone use 10.55 or 10.10.5, the maximum of 25. Is that gone, or are you trying to say is that is the practice that has been followed, but here comes and you feel that is quite high, and then the data you're trying to generate or the research you're trying to coordinate the whole world to come up?
Yes, it's the latter. So that hasn't gone. A few centers are doing what I'm doing, but most centers in the world are still using hydrocortisone 3 times daily. And the belief that hydrocortisone is better, what I've discovered, there's no evidence for it. When you look for the original evidence, it doesn't exist. So no one has done any randomized trials. And one of the problems about research is that in the richer countries where there are drug industries, they are only interested in doing research when there's money in it. And prednisolone is very cheap. There is no income generation for anyone. So there's no drug company. When I say let's do some research on prednisolone, no interest. So that's something that we, the medical profession, have got to do ourselves with the universities, because it's too cheap. So there's no profit motive. But that doesn't bother me. I think I want to know truly what the best treatment is. It might be that hydrocortisone works out better. So we're doing randomized blind control trials, which are funded by the university here, of hydrocortisone compared to prednisolone. So at the moment, half of the UK are saying maybe prednisolone. We're still in a position where they're probably equally used. And the future will go either way. And our study is going to be one of the big ones. But I think if the world joins me, we will have more data, which is what I'd like.
I think you got the right forum and probably right country to speak to, because a lot of people here use prednisolone, as Professor P.G. Sundararaman was mentioning. So it's the right place to show your slide, and people who are interested, we can join.
Okay, that'd be good. The most important thing I'll tell everybody is, if you want to do research, remember it's very easy, but you must record the data. You must record your patient's body mass index, because we do a lot of patients switch the drug, and then if no one's measured it, we don't know if we've got better. So I'm just making a plea to keep all this data. Thank you.
So Professor Miran, can you say hi to Dipesh and Barbara if you see them anyway? Say.
Of course I will. I will be glad to do that. Thank you very much.
Thanks.
Thank you, Dr. Karim Miran. I think there are no more questions. Thank you for a wonderful presentation. And then the new thing that low dose prednisolone, like 3.75 milligram for the replacement. I think Indian country will do, people in the Indian researchers will do much more research.